Sir, sir, 3, 2, 1.
A very good morning to all of you. And once again, welcome to the teaching class of Department of Urology, Sawai Mansingh Medical College, Jaipur. Today, we have a class on medical management of urolithiasis. Will be presented by our resident, Dr. Yash Sharma, and would be moderated by Dr. R.D. Sahu. R.D., if you are there, just start the presentation.
Good morning to all. I request Dr. Yash to start his presentation. Thank you.
Yes, you can share your presentation. Go ahead.
Hello, good morning, everybody. Respected teachers, my seniors, and my colleagues. Today, I am presenting my topic on medical management of urinary lithiasis. So, why is it important to talk about kidney stones? Because we have so much literature of urinary lithiasis since antiquity, and there is global incidence of 1 to 15%. And in Asia, it is 5 to 15%. Regarding the geographical distribution, it is most common in hot, arid, and temperate climates, usually in mountains and deserts. So we found most cases in Rajasthan also, because of the water scarcity also. It is usually coexist with multiple diseases like cardiovascular diseases, chronic kidney diseases, diabetes mellitus, and metabolic syndromes. It also increases burden on the society, not on the diagnosis, but also on the treatment and follow-up. We all know that it is always better to prevent the disease than cure. So points in favor of prevention: fluid intake should be 1.5 liter per meter square, and which produces urine of 2 to 2.5 liters per day, maintaining the specific gravity of more than 1.01. Although there is no such evidence on water hardness, but soft water is causing more stone as compared to hard stones. Carbonated waters and laminates and oranges juice increases the urinary citrate, which causes urinary stone, and carbonated beverages, which causes increased recurrence by acidifying the phosphoric acid. And caffeine also increases the recurrence by increased excretion of calcium and supersaturation. We should avoid excess intake of vitamin C, animal protein, calcium, salt, and urate. And obesity itself is having increased risk of urinary lithiasis. It is independent risk factor for women, and high propensity for uric acid calculi. And high protein and low carbohydrate diet increases the uric acid load in kidney and leads to stone formation. In stone analysis, we found we should do preventive measures in high-risk stone formers, specifically in the patient who having a familial stone formation, early onset of urolithiasis, specifically in children and teenagers, and solitary kidney disease and CKD. Coming on the dietary recommendation, we should intake moderate animal protein, that is less than 1 gram per kg per day, and dietary sodium restriction, because sodium will cause us crystallization of calcium, and avoidance of high dietary oxalate, which is usually found in beetroot, spinach, and soybeans. Dietary calcium avoidance actually increases the stone recurrences, which lead to increased oxalate absorption. And calcium supplementation with meal usually decreases in urinary oxalate. And calcium citrate, which is usually found as a food preservative, which is a calcium supplement, is an additional inhibitor for stone formation. These are the general preventive measures we should keep in mind. Fluid intake should be 2.5 to 3 liters per day, which causes diuresis 2 to 2.5 liters per day. Nutritional advice for balanced diet: calcium content should be 1 to 1.5 gram per day. So salt should be 3 to 5 or up to 5 grams per day. Limited animal protein content should be less than 1 gram per kg per day. So particularly for the treatment part, we all know that the classification of the stones are like calcium stones, calcium oxalate stones, which is more common in acid urine, and calcium phosphate stone, which is more common in alkaline urine. And then comes the Struvite stone, uric acid stone, Cystine, Xanthine, and drug-related stones. There are certain medical conditions which leads to calcium stones. We all know that. Calcium stones are more common abnormalities which having a urinary calcium more than 200 milligram per day. Increased urinary calcium leads to increased saturation of the calcium salts, which leads to crystallization and stone formation. Calcium stone formation having a different pathophysiologies like hypercalciuria, hyperoxaluria, hyperuricosuria, hypocitraturia, and hypomagnesuria. Coming for the hypocalciuria, there are certain causes for absorptive hypocalciuria related to vitamin D, in which a fasting urinary calcium are normal, which it is mainly because of the increased calcium absorption from the intestine. Regarding the renal hypercalciuria, 98% of the calcium is absorbed, out of which 70% in the proximal tubules. Two genetic disorders are there, like Danon disease, which is a X-linked autosomal recessive disease. It is a defect in the chloride channel of endosomes in proximal tubules, which lead to nephrolithiasis and leads to hypocalcemic hypophosphatemic rickets. And the Batter syndrome, it is an autosomal recessive disease which leads to salt wasting, hypokalemia, and metabolic acidosis. In renal hypocalciuria, we know normal serum calcium and high fasting urinary calcium. Then comes the resorptive hypercalciuria, primary hyperparathyroidism, increased calcium absorption in kidney, activation of vitamin D, increased phosphaturia, hypercalcemia, and hypercalciuria. Hypercalcemia induced hypercalciuria, which seen commonly in granulomatous diseases, in which macrophages releases 1-alpha hydroxylase, which increase the production of vitamin D and leads to increased absorption of calcium from the intestine. And then malignancy, which really particularly in lung, breast, and renal and lymphoma, parathormone related peptides, and glucocorticoid induced bone resorption also. Conservative approach toward the hypercalciuria: decreased dietary sodium will lead to hypercalciuria and hypernatriuria, which leads to crystallization of calcium and kidneys, calcium stones. The recommendation for the sodium salt is 100 milliequivalent, which is 2 to 3 gram per day. Then comes the medical management of hypercalciuria: thiazides, which increases the calcium resorption in the distal tubules. The dose is 25. Initial dose is 25 milligram per day, which we can increase up to 50 milligram per day. It should be given with the potassium citrate. The side effects are muscle cramps, potassium wasting, diabetes, hypokalemia, intracellular acidosis. The problem with the thiazides are it loses its hypocalciuric action with the long-term treatment. Then comes the potassium citrate. Potassium citrate supplements is usually given in potassium deficiency patients receiving digitalis therapy or hypocitraturia. Citrate bite calcium and enhance excretion, and it is usually given in renal failure patients, hypertension, and hyperkalemia. Amelioride 5 milligram is usually given in combination with thiazides, is more effective in reducing the calcium excretion. And rice bran oil is also binds the intestinal calcium, which leads to decreased absorption of calcium. Orthophosphates, although there is no such evidence strong evidence regarding the orthophosphates, but there are certain old literatures which showing the orthophosphate also decreases the calcium stone formations. And sodium cellulose phosphate, which we found in market, is a carboxymethyl cellulase, is a oral non-absorbable ion exchange resin bind to calcium, which leads to decreased calcium absorption. The dose is 10 to 15 gram per day divided with meals. The side effects are GI distress and hypomagnesemia and hypopathy. If there is a bruchite stone and having a hypercalciuria more than 8 millimole per day, we should start hydrochlorothiazide initially 25 milligram per day and then up to 50 milligram per day. And chlorthalidone and indapamide is also can be given. Then comes the hyperoxaluria. What does it means? It means more than 40 milligram per day in urine of oxalate usually creates the calcium oxalate stone. It is because of the tubular cell injury and lipid peroxidation. Then these are the major causes, and there are types: primary, enteric, and dietary types of hyperoxaluria. In primary type, it is a rare autosomal recessive disorder, and it usually symptomatic till childhood. It is basically defect in the glycolate metabolism, in which a pyridoxine supplementation will help in 1/3 of the patient. Then comes the enteric hyperoxaluria, which is most common, and in that the cause is chronic disease and pancreatic insufficiency, and usually there is a malabsorption from the small bowel resection or major bypass surgeries. It is associated with the hypocitraturia due to the loss of alkali. And then comes the dietary hyperoxaluria, which is increased absorption or leads to hyperoxaluria. Management of enteric hyperoxaluria is fluid intake should be strongly recommended, more than 2.5 liters per day. Dietary calcium should be given along with the food, and slow release formulation of citrate should be avoided. As instead, we can give this liquid form of potassium citrate, and correct hypomagnesemia by giving a magnesium gluconate or glycinate 1.5 to 1 gram per day. Then management of hyperoxaluria should be low oxalate diet, which is commonly found in spinaches, beetroot, avocado, and brown rice. And medical management, calcium supplementation should be given. High oxalate binding if given along with the food, which leads to decreased intestine absorption. Magnesium supplementation in form of magnesium gluconate, glycinate, which is oxalate binder, and decrease the calcium absorption. The dose of magnesium gluconate should be 200 to 400 milligram per day. The side effect is diarrhea. Then comes the pyridoxine, which increases the expression of catalytic activity of adenine glycolate aminotransferases, which is most commonly missing in hyperoxaluria, which is a key enzyme of the conversion of glycolate to glycine. The dose of pyridoxine should be 5 to 20 milligram per kg per day. The side effect is diarrhea. And the alkaline citrate, it should be given 9 to 12 gram per day in adults and 0.1 to 0.15 milligram per kg per day in children. It is an injectable, subcutaneous injectable medication, which is mentioned in EUA guidelines 2023, lumasirin, which is commonly as a brand name, we found Oxlumo for primary hypercalciuria. We can give initial dose of 6 milligram per kg and then maintenance dose 1 month after. So it is the summarization of a calcium oxalate stone treatment. So we can give alkaline citrate and sodium bicarbonate in a hypercalciuria if it is in a range of 5 to 8 millimole per day. And if it is around 8 or more than that, we can give a hydrochlorothiazide initially and then chlorthalidone and indapamide. In hypocitraturia, which is in which we can give alkaline citrate And in hyperoxaluria, if the oxalate content is more than 0.5 millimole per day, in which we can give a calcium supplementation and magnesium supplementation. If more than 1 millimole per day in primary, so we can give a pyridoxine and injection lumasarin. In hyperuricosauria, in more than 4 millimole per day, we can give alkaline citrate, sodium bicarbonate, and allopurinol. In hyperuricosauria, we can give alkaline citrate and allopurinol. In hypomagnesuria, less than 3 millimole per day, in which we can give magnesium supplementation. In hyperuricosauria, more than uric acid secreting in urine more than 600 milligram per day. In the management, we prescribe adequate hydration, decreased dietary fluid intake, and decreased production, which leads to decreased production of uric acid. Medical management should be given allopurinol, newer xanthine oxidase inhibitor like febuxostate, alkalization of urine, which dissolves the uric acid by giving a potassium citrate, and we should maintain the urinary pH less than 6. Allopurinol indications, as we all seen in the chart algorithm: hyperuricemia, recurrent stone, and chemotherapy. Interference with xanthine oxidase to convert xanthine to uric acid. The dose is 300 milligram per oral daily. The side effects are rash and myalgia. In uric acid nephrolithiasis, hypocitraturia, in which the citrate content of urine is less than 320 milligram per day. The citrate decreases the calcium oxalate formation by complexing with calcium, which directly prevents the nucleation and decreased sedimentation. The causes are medical acidosis and impaired absorption of impaired absorption in GIT, then urine tract infection, and drugs like thiazide and ACE inhibitors. The management, we can prescribe patients to take increased citrate juice, which increases the urinary pH. And in medical management, we can give citrate salts like potassium salts, which increases the alkaline load, decrease citrate absorption in proximal tubules, increase citrate in urine. The side effects are GI upset and hypercalcemia. Hypomagnesuria, in which we have less than 80 milligram per day content of magnesium in urine. The magnesium inhibits the calcium and oxalate crystal formation. It's usually found in irritable bowel disease associated with hypocitraturia and low urine output. Medical management is magnesium supplementation and magnesium rich diet. In uric acid stones, which is found in weak acidic pH, 8 to 10% are the incidence is 8 to 10% out of other stones. 5.5, less than 5.5 pH is favorable for stone formation. The main causes are low urinary pH, low urine output, and hypouricosauria. In the management, we should say to increase the fluid intake, limited non-dairy animal products, which leads decrease in animal protein intake, increase alkaline load by taking fruits and green vegetables, and metabolic syndrome. We should encourage the patient to lose weight, maintain BMI, and glycemic control. In the medical management, urinary alkalization by giving a potassium bicarbonate and sodium bicarbonate. In relapse cases, we can give allopurinol. So in the algorithm, uric acid and urate containing stones, if patient is having a urinary pH less than 5.5, we can prescribe alkaline citrate and sodium bicarbonate. And in hyperuricosauria, if it is more than 4 millimole per day, then we can give allopurinol. And if the pH in ammonium urate stone is more than 6.5, then we can give L-methionine to the patient, an antibiotic for the UTIs. Cystine stone is usually filtered in glomerulus and completely reabsorbed in proximal convoluted tubules. Cystinuria is usually a autosomal recessive disorder, which is a mutation of chloride channel in proximal tubules. which leads to decreased absorption of cysteine, lysine, and arginine. The solubility of cysteine depends on cysteine concentration, urinary pH, ionic strength of urine, and urinary macromolecules. In the management, adequate hydration should be the key preventive measure, and intake of alkalization of urine to maintain the pH more than 7.5 by giving alkaline citrate and sodium bicarbonate. In dietary measures, restriction of animal proteins to avoid methionine and low sodium. Medical management increases the solubility, more mixed disulfide bond. Examples are alpha mercaptopropioneglycine, D-penicillamine, and captopril. D-penicillamine, the dose should be starting dose around 250 milligram per day and should be titrated according to the effect. And for the dose, alpha mercaptopropioneglycine dose should be 100 milligram per oral twice a day. And captopril, which is commonly found in market as a Captotag or Captocare, it is a ACE inhibitor. The initial starting dose should be 25 milligram per oral twice a day. In infective stones, struvite stones, magnesium ammonium phosphate stones, alkaline media is the most reason for bacteria to grow. Gram-negative bacteria, Proteus, Klebsiella, and Pseudomonas are most common. In gram-positive, Staphylococcus aureus and epidermis are more common. Overall, E. coli is the most common commensal of UTI, which produces UVS. A favoring factor for stone formation in high pH, sufficient carbonate, and ammonia and phosphate. The management should be more towards surgical rather than medical, and to prevent recurrences, antibiotics should be given. Acetohydroxamic acid, which is commonly seen in market as a lithostat. Urease, it is a urease inhibitor which reduces the urine saturation of struvite. The initial doses should be 250 milligram twice a day and can be given 3 times per day as per the titration. The side effect should be thromboembolic phenomena, tremors, headache, anemia, alopecia, and abdominal pain. It is usually reserved for the patients who are too ill for surgical management. The contraindications are CKD with having creatinine more than 2.5 and pregnant women. In struvite stone, we should acidify stone, and meant for pH less than 2.5, we should give L-methionine and ammonium chloride, and dilution of the urine. And chemolysis also is the treatment part, which have 2 types. One is oral and one is percutaneous. Percutaneous Subias solution having 10% hemosiderin is mainly for the struvite stone and uric acid stone. It dissolves residual fragments after surgery. And renal pelvis, we should irrigate the renal pelvis after 4 to 5 post-operative day with a rate of 120 milligram per hour. And we should keep irrigation for 24 hours till the last radiological visible fragments have disappeared. And in oral chemolysis, we should know that we already know that by doing a alkaline citrate and sodium bicarbonate, we can chemolyze it. This is the algorithm in EUA guidelines for infective stones, struvite stones. Then comes the xanthine and hydroxyl adenine stone, which is highly insoluble and radiolucent stone, and xanthine deoxidase deficiency, which leads to accumulation of xanthine. There is no such specific medications to prevent or treat these stones. Alkalization should be done in all these patients for prevent the recurrence. Medical expulsion therapy, which is usually there is strong evidence for medical expulsion therapy for the stones more than 5 mm, less than 5 mm in distal ureteric stone, distal ureter. So in MET, we give alpha blockers, calcium channel blockers, and phosphodiesterase 5 inhibitors. Out of these 3, alpha blockers only having the strong recommendation for MET. The mechanism are it will relax the smooth muscles in the ureter. The contraindications are pain, sepsis, and derangement of RFT and hypotension.
ये बताओ why is pain a contraindication of using alpha blockers? Pain में तो देखते हैं यूरेटिक स्टोन कौन सा है जो pain है? Why is pain a contraindication?
So sepsis with pain.
I'm not sepsis की बात है ना, pain तो contraindication है यार.
We will discuss it. Yeah.
Then comes the summary of medication, which we already see. Alkaline citrates, which the dose should be 5 to 12 gram per day, and in children 0.1 to 0.15 gram per day. It is usually given in calcium oxalate and uric acids and cystine stones. Then allopurinol, which is starting dose of 100 to 300 milligram per day, which we can give in calcium oxalate, uric acid, and ammonium nitrate. And dietary calcium should be up to 200 milligram per day, depending on the oxalate excretion in calcium oxalate stones. Then the captopril, the dose is 75 to 150 milligram, is given in cystine stones. Then xanthine oxide inhibitor, febuxostate, the dose is 80 to 120 milligram per day, usually given in calcium oxalate and uric acid stones. Then L-methionine for acidification, the dose is 600 to 150 milligram per day, and usually given in infective stones and ammonium urate and calcium phosphate stones. Then supplementation of magnesium by giving magnesium glycinate, the dose is 200 to 400 milligram per day. In children is 6 milligram per kg per day. In calcium oxalate stones, and sodium bicarbonate for alkalization and hypocitraturia in calcium oxalate and uric and cystine stones. Then the pyridoxine in type 1 primary hyperoxaluria, the initial dose is 5 milligram per kg per day in calcium oxalate stones. And thiazides in hypercalciuria, calcium oxalate and calcium phosphate, and tiopronin for active decrease of urinary cystine level. The initial dose is 800 milligram per day in a cystine stone. The main drawback of hydrochlorothiazide is patient is having a non-melanoma skin cancer and some form of melanoma in old. Thank you.
Thank you, Dr. Yash. So, good presentation. You saw the first slide, the way he presented. He just made a few points and then elaborated on it. I think that is the way to present. So, good presentation. And I think we should improve even more, right? The few points that I had told you about putting the references whenever you are putting facts, right? Like high fluid intake. So what is the evidence? So that evidence should be there always in a footnote. Similarly, hardness of water, there's still no evidence. So you should give, there is still no level of evidence for hardness. So I think in this way you can improve your presentation, and I think we should keep on improving. Medical management is something I think feel that is neglected, and we should put more stress on this part of the management of urolithiasis. Surgical, we all know, definitely we can help these patients, because these patients, even with all kind of technology and surgical skill and everything, the prevalence of stones are increasing. So it is not helping the patients. So what can help actually the patient is how to prevent stone formation. So this part of the management, I think we need to stress upon. So prevention could be done either to prevent the recurrence or prevent the growth of the existing stones. So we discussed the various kinds of management, and that could be, one is a general management, the other is a specific management. So general would be for almost all kind of stones. So that could be the lifestyle modification in the form of fluid intake, dietary modification, reducing your weight, and all these, and taking a lot of fruits and vegetables. That is, I think, general and is good for all kind of stone formations, and good for your health also. Secondly, the others are stone specific. So I think most of us should now make a habit of doing a metabolic evaluation in these patients and know exactly whether there is a hypercalciuria. We did not divide them into absorptive, resorptive, and all that kind. So just a hypercalciuria is present or not. Hypercalciuria, hyperuricosuria, hypocitraturia. So based on that, we can manage these patients and help them to prevent the recurrence of stones. So I think a very important thing here to understand. And I think the last chart that he made on the different medications available for various types of specific management, I think it's very good. You should, I think you just make a poster kind of thing and put it in the board, right? So that we can, it can help us to counsel the patients on what type of drugs are required in a particular kind of a stone. So thank you. If you have any kind of query, suggestion. Yes, that's very important, a very relevant. And I could not also understand why pain will be a contraindication for medical expulsive therapy, because pain is the symptom of uric stone. So did you see that? Do you have any answer to it? So again, another important point is, if you don't know a particular thing, don't write it. Yeah, just write a thing. Why it is written? It's a very, very relevant thing. How can a pain be a contraindication in a patient of distal uric stone, where the almost majority of the patients will have a colic or pain, right? So it contraindicates almost all the patients. Yes, go ahead. Yes.
Said about antibiotics, all over antibiotics and infective stones. But as I read in some articles, there is no particular duration, 4 weeks, 6 weeks, or 7 weeks, some book says 1 week.
I think Dr. Adi Sahu has a question. He is also a moderator of this presentation. I will just ask him to just put it on mic.
So you said in one slide the role of the antibiotics in infective stones. What is the duration, doses? It is what dosage of suppressive type or what?
Guideline for a specific duration of antibiotic. You should give the antibiotic according to the culture.
The culture is not always positive, as you was seen in our day-to-day practice. Because the patient is on always antibiotic before operation or surgery.
What do you think? आपके पास कोई आंसर है?
एक साल तक
Give your answer.
एक साल तक
Give 1 year.
More than 6 weeks, was 6 months.
एक साल. I putting it at 1 year.
Which
Which we do not give.
yes,
Which we do not give. I have I read this, that if you are dealing with a matrix or infective stone, then sterilization of the system sometimes would require a minimum of 6 months, and you have to give low dose antibiotic for 1 year.
Right. So Nachiket and Dr. Adi has a point here that those we get often infective stones, Struvite stones, and how long the antibiotics to be continued, and if the culture suppose is not positive, do we need to give empirically antibiotics or not? And this is a point of I think concern, and we need to look into it exactly. So what Nachiket and Dr. Adi was saying, that it should be given maybe for 6 months or even more than that. 1 year. 1 year. So I think that is an important point to be made. And besides this, about the urine culture, we had a kind of study on stone culture. So all these patients you suspect infective stones, it's better to culture the stone also to know the exact organism, and then we can even give antibiotics according to it. So that's, I think.
We did that study of even when the stone should be crushed.
Yeah.
Because the surface bacteriology is different from the nucleus bacteriology.
Yeah.
In 20% of cases.
Yeah, very good point. This study was done by Dr. Nachiket and his team only. And Nachiket, go ahead.
So, sir, we got this study done, and then in one of the north zones, we also presented it. And difference of the culture of the stone surface and the culture after the stone is crushed. And even in literature, they say that a different bacteria can be present if you crush the stone and you get the culture done from the nucleus. So 20% of the times the culture would be separate. And again, I think 1 year we can give a bacteriostatic after, depending upon the culture. Once you are sure that the pelvic leachal system is sterile, then we also give bacteriostatics for so many years in reflux. For example, if a patient comes with reflux at 5 years, 6 years, then we give it till puberty. We give it till for 5 years, 7 years, 10 years. Jab tak wo bacha, he doesn't attain puberty. So I think that is just a mindset that we think that why should we give antibiotics or bacteriostatic? But if the patient, again, otherwise the patient will develop these stones again. So I think that there is no harm in putting the patient on a low dose bacteriostatic like a nitrofurantoin, which still has got a good sensitivity, or a trimethoprim, which is a good bacteriostatic for 1 year.
Allopurinol is for hyperuricosauria. How long? I think we should maybe follow up these patients and do another 24 hours urine evaluation to know whether this hyperuricosauria has resolved or not. So if is still not resolved, we should continue. If it is resolved, then we may stop for a time being and then do it again to see whether it is again coming up or not. I think some of these patients may require for a very long term these drugs, because they have a tendency to develop hyperuricosauria. About infective stones, besides antibiotics, the 2-3 things which are important, you also mentioned about it, is that don't give alkalizer to this, because many of these patients, actually they form stones in alkaline pH. So we have a habit of giving citrate and all this to most of these patients. So don't give alkalizer to these patients, which will rather promote stone formation. And thirdly, we have a drug as a urease inhibitor. So, so that drug also can be acetohydroxyl acid. So that can also be given if we know that this is a protease or a organism which is a urease inhibitor. So I think that's it. If you have anything else, otherwise, Dr. Adi, I would request our moderator, Dr. Adi, to kindly wind up that.
Use of alkalizers in dysuria also.
Yeah.
It should be, I mean, stopped.
Not.
Because you're giving a chance of more other agents, common agents like E. coli and Klebsiella, because they propagate inside the alkaline.
I think it's very important that just an empirical use of alkalizer should not be encouraged. If we know that the urine pH is less than 5.5 as recommended, then definitely alkalizer is required. Otherwise, I think we should not give as a blanket therapy. So, Adi, we would ask you to have your last comments and wind up the session.
Thank you, Shivam sir and Nathika sir, for enlightening us by their experience. Thank you, everybody. Thank you.
So have a good day, everybody.